So good evening to all. On behalf of IRA Kerala, I welcome all the attendees who are present here. And today actually this PG case presentation on hepatobiliary pancreatic, hepatopancreatic system. And we have got a few cases, and this should have been there actually on yesterday, but for some reasons actually this could not be conducted yesterday, so that was postponed to today. And in this occasion, I welcome Dr. Gomathi Subramaniam, President, IRA Kerala Chapter, Dr. Rijo Matthew, Secretary, IRA Kerala Chapter, and Dr. Ramesh Shenai, Program Coordinator. Actually, because of these people, actually, we would be able to conduct this program regularly. And as everybody knows now, this Wednesday is actually, it is the day of residents. And today we have got 3 residents, Dr. Nubur Shah, Dr. Linda Joss, and Dr. Pribin Bright. And all are from Amrita Medical College, Kochi. I welcome all of you for this program. And this program is being moderated by Dr. Rajesh Kannan. He is a professor, Department of Radiology, Amrita Institute of Medical Science, Kochi. And he is coordinator also, one of the coordinators. I welcome Dr. Rajesh Kannan. And now over to Rajesh Kannan.
Thank you, sir. Thank you very much for giving us this opportunity. So, without wasting time, we'll now move to the case presentation. So, today we have 3 interesting cases involving the liver and or the pancreas. So, they are a little unusual cases, not very common, but exam point of view, these are all very important. So, today what we are going to show you is how to approach these cases. So, the final diagnosis is not very critical, but it's for the residents point of view, it's you should know how to approach these cases and know how to have a different diagnosis, and then finally to make a diagnosis. So, first we will start with the case. Dr. Nupur, you can start.
Good evening. Good evening, esteemed professors, friends, and colleagues. I am Dr. Nupur Jha, pursuing second year PG resident, pursuing MD Radiology from Amrita Institute, Kochi. It's my extreme pleasure to present this case in front of all of you. This case is about a 45-year-old female who came with recurrent vomiting and weight loss. Then she got a multiplanar contrast enhanced CT abdomen done with planar imaging, which showed diffuse rugal thickening involving fundus and body of stomach, multiple enhancing nodules involving proximal duodenum, and enhancing nodule involving head and uncinate process of pancreas. However, there was no main pancreatic duct dilatation. There was no calcification in rest of the pancreas. Liver appears normal with no focal lesion. However, because this patient is post cholecystectomy status, so few of the clips were seen on plain scan. Also, spleen was normal and there were no focal lesions in spleen as well, and enhancing lesions as well. Bilateral kidneys were showing multiple cysts involving all the poles with few calculi in right kidney. There was no fluid. There was no fluid in the imaging. So this is this is the arterial phase, sir. So
Yeah, you can keep this two slide and we'll have the discussion.
Yes,
So,
sir.
so what is the main findings
Sure,
in
sir.
these two
Sure.
slides? Can you show the
Yes, sir. I'll
findings?
just show you, sir. Yes, sir. Yes, sir. Yes, sir. Sir, there are multiple, this diffuse rugal thickening is there in the stuff involving fundus and body of the stomach, and multiple polypoidal lesions. Also, there are few polypoidal lesions involving duodenum and a big solid soft tissue attenuation lesion involving head and the uncinate process of pancreas. And also, sir, there is one gastroduodenal node over here, which is also enhancing, sir. And these are the main findings, sir.
Okay, so first we will concentrate on the pancreatic lesion. So you said the lesion is involving the head and the uncinate process of the pancreas. So how will you approach that not this type of lesion? So what are all the findings you have to look for to characterize the lesion further? The pancreatic lesion.
Yes, sir. Sir, yes, sir. Yes, sir. We can. First of all, the location, sir. This lesion is particularly involving the head and uncinate process of pancreas. Also, this lesion is like equally enhancing with the rest of the pancreatic parenchyma. Also, sir, in this case, there is no main pancreatic duct dilatation. There is no biliary obstruction. There is no intraparenchymal, like pancreatic parenchymal calcification, sir.
Okay, so we'll come to one by one. So you told the enhancement
Also,
is similar to the pancreas. Suppose if it is enhancing less than the pancreas,
yes,
what
sir.
will be your diagnosis? If it is enhances more than the rest of the pancreas, what are all the possibilities? So if it is enhances less than the normal pancreas.
Sir, if it is, sir, then it can be adenocarcinoma, sir.
Okay.
That
Yes.
will be hypodense.
Yes. If it enhances more
Yes,
than
sir.
the pancreas.
So then it can be some hemorrhagic lesion,
Oh, it is a
or it can be some
hemorrhagic lesion.
hemangioma.
How commonly you see hemangiomas there in the pancreas?
Sir, very, very rare, sir. Very rare, sir. I
Okay.
understand.
So what will you think of common thing? So which pancreatic lesion will enhances more than the background pancreatic parenchyma? Neuroendocrine tumor, no?
Yes, sir. Yes, sir.
Okay. So basically, when you are seeing a lesion which is enhancing brighter than the background parenchyma,
Yes,
then
sir.
the most common
Yes, sir.
the causes are the neuroendocrine tumor involving the pancreas. The locations are different, so it can involve the any part. So basically, the two common things you have to look at it. One is if it is hyper-enhancing, you won't straight away think of say malignancy. It can be just a pancreatitis, focal pancreatitis. It can be pancreatic necrosis. Benign things also can be hypodense. Or it can be like say adenocarcinomas are usually hypovascular. And other things, cysts, these are not anyway cystic lesions. So cystic lesions, the DDs will be different. Whereas if it is a hypovascular solid lesions, either you have to think of a focal pancreatitis, or it can be a say focal pancreatic necrosis, or it can be things like adenocarcinoma. Yeah, some of the common things we are discussing. As well as if it is a hypervascular, then you can think of a common things like the neuroendocrine tumor. Okay, that is the one. Then you told the CBD and the PD is not dilated. So what is the importance of that? If it is dilated, what will be your BD?
If it would have been adenocarcinoma,
Yeah,
then
would, basically it indicate a malignant, more stricturing type of tumor, very aggressive type of tumors like a periampullary or a pancreatic head malignancies. Generally adenocarcinomas, you will see what is known as the double duct sign. What is double duct sign?
yes, sir, main pancreatic duct will be dilated.
Yes, main pancreatic duct and the common hepatic duct.
Common hepatic duct.
Yeah, both will be dilated. Then you will call it as the double duct sign. Yeah, so that usually indicative of usually a much more aggressive lesion. So here they are not dilated. Then you told
Yes.
regarding the calcification. So what are all the What is the importance of calcification? So, what are all the pancreatic lesions that can have calcification?
So chronic pancreatitis, chronic calcific pancreatitis.
Okay, so in that you will see the underlying pancreatic parenchyma will showing a calcification. What about
Yes, sir.
any mass within the mass? If you see a calcification, what are all the possibilities? Pancreatic
Sir,
mass with the calcification.
mucinous,
Okay,
mucinous cystadenoma of pancreas, sir.
okay, so that will be cystic tumors generally.
Yes, sir. Yes,
Okay,
sir.
so solid tumor with the calcification.
Sir, metastasis.
Metastasis to pancreas is rare.
Yes, sir. Yes, sir.
So always you should know what is common condition. See again, neuroendocrine tumor is not very rare. What about neuroendocrine tumor? Will it show calcification?
Sir, I'm not sure, sir.
Yes, see neuroendocrine, one of the major differences between neuroendocrine tumor and adenocarcinoma is adenocarcinoma usually hypovascular and it won't calcify, whereas neuroendocrine tumors so commonly calcifications and they are
Okay, sir.
hypervascular. Okay, so these are all the two main differences between the two. Okay, so you have to look for calcification because they are common in the
Okay, sir.
neuroendocrine tumors. Okay, so the enhancement is important, calcification is important, cystic changes are important, as well as the whether the pancreatic duct is or the common hepatic duct dilated or not, all those things are important. Okay,
Yes,
yeah.
sir.
So considering this, there are no definite features of a adenocarcinoma, and
Yes, sir.
if suppose if you are thinking of a neuroendocrine tumor,
Yes, sir.
why this is not enhancing more than the pancreas, which you will expect in a neuroendocrine tumor? So how will you otherwise time the scanning for the neuroendocrine suspected neuroendocrine tumor?
Sir, pancreas protocol will follow, sir.
Yeah. So you have to take a early arterial phase. So only in that phase it will show hypervascularity. But if you don't do the correct phase, then it can appear relatively isodense. Okay. Fine. Next, coming to the gastric some wall thickening. So what are all the possibilities for that?
So it shows diffuse rugal thickening, sir. So there can be Meniere's disease, there can be Zollinger-Ellison syndrome, sir, eosinophilic gastritis, and hematometasis, sir, Peutz-Jeghers syndrome, sir.
Yeah,
It
so yeah, commonly you will think of polyps or versus the diffuse gastric wall thickening. Okay, yeah, so these are all the DDs. And what about the renal cyst?
yes,
So
sir.
what are the causes of renal cyst?
It can be either hereditary cause like ADPKD, sir, autosomal dominant polycystic kidney disease.
Huh.
Also, it can be cystic pelvic Ellison cystic dilatation, or it can be medullary sponge kidney.
Yes, yeah. So there are so many causes are there. Can be simple cyst, as
Yes,
part
yes.
of the old age. It can be associated with the genetic, both autosomal dominant or autosomal recessive cyst. Then you can have hemodialysis associated. Cyst. So there are so many other conditions, cystic tumors. So these are all the possibilities. Anyway, we are not going to concentrate today on the renal. We'll be concentrating mainly on the pancreas. Okay, you can go to the next slide.
So this is again the coronal sections there. So just showing that the rugosities and the polyps, rugosities thickening and polyps are sparing the antrum, sir. It's mainly involving the body and the fundus of stomach.
Yes. So generally, in many of the diseases, what you have described, you'll expect the entire body and the antrum, everything to be involved in a homogeneous manner. So here, but these polypoidal lesions predominantly involving the fundus and the proximal body, whereas the distalmost body and the anteropyloric regions are relatively spared. Okay. So I'll recommend the other delegates, if those whoever is interested can give their answer or the diagnosis in the chat. We can discuss and we can say why it is not that particular diagnosis. Okay, yeah, I can move on.
Yes, sir. So these are the CT findings. The stomach, I actually already described this. So stomach shows multiple irregular polypoidal thickening. multiple enhancing solid lesions involving head and uncinate process of pancreas and enhancing nodes adjacent to peripancreatic lesion. Also, sir, right adrenal gland was appearing bulky and it shows a hypodense nodule with attenuation of around, sir, 5 to 9 Housefield units.
Yeah, can you go back? Someone is saying why it's not a lymphoma. Okay. Previous
Yes,
slide.
sir. Yes, sir.
Yeah, can you explain why this is not a lymphoma?
The lymphoma will be more diffuse. There will be more infiltration, more wall thickening will be there. Also, sir, lymph nodes will be involved diffusely till below the renal hyla.
Yeah, so will it be hypervascular or hypovascular?
Lymphoma will be hypovascular.
Yeah, so usually it won't enhance very well. Okay, and they will have a tendency to encase the retroperitoneal vessels like aorta and IVC. Okay, whereas the gastric lesions can be, but it won't be like this. Nodular polypoidal type of things are little unusual. Okay, fine. Okay, next.
Yes, sir. The right adrenal gland shows a hypodense nodule with house
Okay.
membranes. Yes, sir.
Next.
So these are the differential diagnoses for stomach rugosital thickening, Peutz-Jeghers syndrome, adenomatous polyp, carcinoid, lymphoma, of course, sir asked, hematoma, and hemangioma. Also, sir, the lesion involving head and uncinate process of pancreas, and those ladies, according to me, are neuroendocrine tumors and hemangioma, which is again very rare, sir, in pancreas. Then, sir, this patient got a CT neck with contrast done, and it showed a hypodense nodule involving the inferior aspect of left thyroid, sir. Then one ultrasound correlation was done, which showed a hypoechoic lesion in inferior aspect of left thyroid with rim vascularity.
So
This is
go
the
back. So if you
ultrasound.
see a lesion like that, what are all the possibilities you'll think of? Yeah.
It can be parathyroid adenoma, sir.
Okay. Then
Yes, sir.
what are the other DD for a lesion at the tracheoesophageal groove? Do you know any other structure running in that location, tracheoesophageal groove?
It can be any tumor, sir.
Yeah. Any nerve runs with that tracheoesophageal groove? Here, can you show the trachea and the esophagus?
Yes, sir. Okay.
Do you have arrow pointer? Yeah. So you can have nerve sheath tumors anywhere. Okay, it can be lymph nodes. Yeah. So that is a lesion. That is a trachea and esophagus. So you have recurrent laryngeal nerve is running in that. So you can have the tumors of that nerves and all. Okay. Or it can be a exophytic thyroid lesion.
Yes, sir.
Okay, but generally thyroid lesions are more vascular and will be usually hyperdense. Okay,
Okay, sir. Okay,
right?
sir.
Yeah. Next.
Yes, sir. So ultrasound correlation showed hypoechoic nodule with internal vascularity and peripheral vascularity, sir.
Yes.
Then, sir, one MRI pituitary was done, which showed again high nodule in right aspect of in right half of pituitary, which was showing hypo enhancement, which was and it was measuring 6 millimeters, sir. So it was basically suggestive of microadenoma.
Okay. Yeah.
Then, sir, yeah, sorry, sir. Then, sir, when Dotanak whole body PET CT scan was done for this patient, which showed uptake, and the uptake was seen in stomach, parathyroid, pituitary, and pancreas.
So
Also,
what
the
is this
tumors.
Dotanak scan? Can you explain?
So basically, the tumors which have somatostatin receptors, sir. So we'll be using one somatostatin analog. With that, we'll be showing uptake like that analog will be showing that analog will be uptaken in the tumors which have somatostatin receptors, sir. So we use octreotide. OC is octreotide, sir, and so
Yes. So basically, it is very much useful where there is a somatostatin analog expression. So all the whenever you are suspecting any neuroendocrine tumors, This is a very useful thing. And in this case, anyway, we know that the pancreatic lesion is so hypervascular, and there are other features of the multiple endocrine neoplasia. There are people already is suspecting that like a parathyroid, pituitary. But the important thing is the involvement of the stomach. As you rightly pointed out, the stomach involvement can be due to the Zollinger-Ellison syndrome, where you can have the gastric wall thickening, polypoidal mucosal thickening, versus the neuroendocrine tumors involving the stomach itself. Okay, so in this case, clearly both the pancreas as well as the stomach is showing an uptake, as well as can you show that parathyroid uptake? Can you use the pointer? As well as pituitary, normal pituitary also sometimes can show uptake with this DOTA. And as well as in addition to this, you are picking up some liver lesion, isn't it, which is not seen on a conventional CT scan. So that is the advantage of DOTA scan.
Yes, sir.
Can you show those lesions?
Yes, sir. This is parathyroid uptake, sir. This is pituitary uptake, sir. This is not coming. No, sorry. Okay. Yes, sir. This is liver uptake, sir. This is stomach. This is pituitary uptake, sir. This is parathyroid uptake.
Yeah, and in the coronal only we can see that liver lesions, very tiny
Small
ones, very
yes,
tiny
small
ones.
ones.
Yes,
Yes.
yeah. Okay. Yeah, go ahead.
So to conclude, in our case, mainly 4 organs were involved: stomach, pancreas, adrenal, and pituitary glands. Summing up, these findings in this case point towards possibility of syndrome, and with imaging features are consistent with multiple endocrine neoplasia type 1 syndrome. Sir. Also, on biopsy, it came as grade 1 neuroendocrine tumor. So this is just one comparison between MEN1, MEN2A, and MEN2B. I'm just trying to show the organs involved in this syndrome.
Yeah, can you explain what are all the organs involved in 1, 2, and 2A, 2B?
Yes, sir. Yes, sir. So in MEN1, basically pituitary, parathyroid, and pancreas is involved. So in MEN2A, which is also known as Sippel syndrome, that will involve that will cause hyperparathyroidism and medullary thyroid carcinoma and pheochromocytoma. Sir, in MEN2A and MEN2B, in both of them, pheochromocytoma is a common thing, and medullary thyroid cancer is a common thing. However, in MEN2B, there is one more added feature, that is Marfanoid habitus and mucosal neuromas.
Yeah. So MEN2A nothing but the two things almost always is there, medullary carcinoma and pheochromocytoma. Whereas in the MEN1, almost always you have a pituitary, pancreas, and the parathyroid, almost like a triple P, syndrome. Okay.
Yes. Yes. Sir.
And in addition, you can have adrenals and other lesions. Okay.
Yes. Sir. Yes.
Yeah.
Yes.
So whenever you see multi-system involvement, you should know how to approach those type of cases. So whenever in the exam, when you get a case like involvement of abdomen, neck, and the brain, so one of the DD include this multiple endocrine neoplasia. Okay.
Okay,
Fine.
sir. Okay, sir.
Yeah, we'll move to the next case.
Thank you so much, sir. Thank you. Thank you to all the professors. Thank you.
Yeah, Bribin, you can show the next.
Okay.
Someone asking adrenal, yeah, so because yeah, we were concentrating mainly in the pancreas, it didn't show that, but there was a nodule in the adrenal also in this case.
I'll share. Good evening, sir, and respected faculty here. I'm going to present an interesting case in retroperitoneal mass involvement involving the liver. I'll just share 1 second.
This recorded video will be available, so you can watch again. Someone is asking to show the case again. Yeah, definitely you can come back and watch the case again.
Sir, the slides are visible?
Yes.
Yeah. Today I'm presenting a puzzling case of retroperitoneal mass with hepatic involvement. In our case, a 66-year-old female with no significant past medical history presented with right-sided abdominal pain and fullness of 3 months duration, which got aggravated since 2 weeks. And there was associated right lower limb edema for the past 5 months. There was occasional shooting pain radiating to the right lower limb, and there was associated loss of weight and loss of appetite. There was no associated history of nausea, vomiting, bleeding by rectum, or hematuria. No history of fever or chills, and no history of altered bowel habits. On examination, vitals were stable. There were no pallor, jaundice, or generalized lymphadenopathy, and right lower limb showed edema. Perabdominal examination showed a large non-tender mass, mainly in the right side of the abdomen. Going to the imaging findings, the primary Doppler evaluation revealed a heteroechoic lesion in the abdomen, measuring almost 12 into 16 centimeter with central and peripheral vascularity. And the DVT and the lower limb Doppler, there was no evidence of DVT. And going to the CT findings, this is a plain CT taken here.
No, so from above, not that much. Don't make it that big. Yeah, so the upper two rows. Yeah, okay. Yeah, fine.
Okay. Here, you can see a heterogeneous lesion involving the right lobe of liver and a part of caudate lobe as well. And this mass is seen extending into the.
Can you characterize it further? So whenever you are seeing a lesion, what else you will be looking for?
Yeah, actually, we should see any other lesion is there in the liver to see if it's a hepatic-based lesion or a hepatic mets or anything.
No. The lesion alone, you have to characterize it further. So with the lesion, what is the characteristic on plain scan?
It's a heterogeneous, it's a heterogeneous appearing lesion, which is seen in the right pararenal space, which is displacing the.
Don't move. Please don't move. Keep it there. Yeah. Just you describe the lesion alone. Don't move. Whatever the slides upper two rows, you just.
Yeah, here we can see a heterogeneous large mass in the right pararenal space, which is displacing the right kidney and pancreas anteriorly, and which is almost engaging the IVC and partially engaging the aorta and renal veins.
Now, what are the other things you have to look at it in a plain scan? So, the extent of the disease lesion and all, you can see it in the post contrast also. On a plain scan, what are the things you have to look at it?
There is no calcification, sir.
Very good.
There is no fat content.
Yes, good.
And some necrotic appearing areas are there, sir.
Yes, there are central hypodense areas are there which may represent necrosis. Yes. What else? You have to see it in a plain scan.
Plain scan actually.
You have to look for evidence of hemorrhage also. Bleed. See, the bleed will be seen only on a plain scan. If you don't see it on a plain scan, you will be completely missed on a post contrast scan. Okay. As well as similarly, calcification itself sometimes can be seen in the post contrast, but the bleed is the one always you have to look at it into the plain scan, because sometimes commonly people miss that one. So you have to look for any lesion, you have to describe it, whether the lesion contains cystic changes, whether it has a calcification, whether it has hair, or it has the hemorrhage, all those things, it's very important. Okay.
Yes, sir. Sir.
Because why I am saying this, see the same type of a lesion, one of the important common exam case is the duodenal hematoma. Okay.
Okay, sir. Okay.
So only on a plain scan you will be able to pick it up. Okay.
Okay, sir.
Yes. Yeah. Next.
Yeah. Moving to the arterial phase, there is the large mass which is in the retroperitoneum, which is showing enhancement on arterial phase, and there is some non-enhancing areas also within, which confirms the necrotic component of the mass. And also, the aorta, the mass is partially engaging the aorta here, but it is not infiltrating into it. And celiac artery is also is closely abutting the celiac artery, the renal artery, and like hepatic arteries also. But none of them are like invaded or and one other thing is that like this mass is actually pushing the aorta and other vessels to the left side of the abdomen, which means it is arising from the retroperitoneum, possibly the pararenal space.
Why this is not a liver mass?
Sir, if liver mass, if it was a liver mass, it should be like showing enhancement, like very good enhancement, because it will be getting its arterial supply mainly from the arterial phase. I mean,
No.
arteries.
See, there are many liver tumors which can be hypovascular. Even hepatocellular carcinoma sometimes can be hypovascular. So you generally won't look only by the vascularity, to identify the site of origin. Okay,
Yes,
so the important clues will be the involvement of the, when it is especially bulging outside or going downward. So the important clues will be relationship to the retroperitoneal structures, like adrenal gland,
okay.
or the aorta,
Yeah.
IVC. Okay,
Yes, sir.
if it is a lesion, if it is hypervascular, then you have to look at the hepatic, the feeding vessel, whether it is
Okay.
getting feeder from the hepatic artery or any other
Okay.
things. Could this
Okay.
lesion be from adrenal? Can you able to see the adrenal gland separately?
Yes, sir. Adrenal gland we can see separately.
Yeah. So can you show that? It is seen in the third row.
Yes, sir. This one.
Yes. Yeah. So right, adrenal gland is seen separately. So that means it's not from
Yes,
the
sir.
adrenal gland.
Not
Yes.
from the adrenal.
Yeah.
If
So
there is like, okay,
uh,
then
if it is usually from adrenal gland, generally the IVC will be displaced anteriorly. Okay, so here
anterior, yes, sir.
IVC is not seen separately, so we cannot comment on that. Then could it be
Yes,
from
sir.
the kidney?
Kidney, actually we can see my major part of the kidneys here, sir.
Yes.
And it's like the veins are, I mean, like arteries are patent in the renal arteries are present, which is enhancing in the corticomedullary phase.
Yeah.
And actually,
Whether
next
the
slide we
renal,
can see
whether
more.
the renal mass can extend into the liver like this? If it is a renal mass,
Possible,
see, if it is
like
a renal mass, can
if
it extend into
yes,
the liver like this? How?
yes, sir, possibility is there, sir.
Yeah, see, if it is involving the renal vein and through
Like,
IVC, it can
it
extend
can
into
spread
the,
into,
even extend into the right side of the heart, even into the pulmonary artery, can produce
yes,
pulmonary emboli and all. Okay, so you have to
yes,
keep that as a possibility.
okay,
Then it can be a primary retroperitoneal lesion.
yes, sir.
So if it is a primary retroperitoneal, yeah, then you will see the next images.
Yes, sir.
Yeah,
Here,
just
actually, we can see the superior, like this mass is extending superiorly into the right atrial and caval junction, like cavo-atrial junction, and here also, like this is the venous phase, and you can see the middle hepatic veins are involved. Right and middle hepatic vein is involved.
can you use a pointer and show that
Okay.
hepatic venous involvement?
This one, sir. Yeah. Sir, this
Yeah, in the upper cut, one row above, there you can see now some filling defects, little anterior, that is the mass in the IVC. Yeah, that filling defects are the venous middle hepatic vein and the right hepatic vein. There are filling defects are there. Okay, so that means the lesion may be extending into the hepatic veins also. Okay, yeah. Next.
Here you can see the entire kidney is free from the tumor, and the mass is actually extrinsically compressing the kidney and causing negative embedded signs, forming a crescentic shape of the organ, which rules out the renal tumor.
Okay, so at this point, can this be a lymphoma?
Lymphoma, it will be a rare. I mean, like it is unlikely, sir, because there should be homogeneous. Mostly lymphomas will be homogeneous involvement.
Yeah, so generally it will show a homogeneous, not very high vascular. It usually won't show necrosis unless it is treated. Here you are seeing definite areas of necrosis. And other thing is usually it will have a tendency to encase the aorta also. How is the aorta here?
Here aorta is partially abutted,
Mainly displaced. Yeah, it's not encasing the aorta. No, it is just displacing the aorta, not encasing it. So if it is encasing the aorta under the IVC, then that is much more classical of lymphoma. And generally it will be homogeneous mass, not it won't show a central necrosis. And extension along the or into the liver like this is very unusual. It can just directly involve the liver or displace the liver, but it won't go into the liver like this. Okay.
Yes.
Okay. Next.
Yes.
Yeah. Describe it. What is the finding here?
Here actually we can see the excretion, the renal pelvis here.
Yes. So most of the part of the kidney is you can see it displaced, and it's very unlikely to be a primary renal mass because most of the kidney is displaced. Okay. Yeah. So that means what is your more likely possibility with this?
It points towards the retroperitoneal mass, because the epicenter of the mass you can see here, it is mostly into the bulk of the mass is.
Okay. So what are all the common retroperitoneal masses?
And the possibility of liver and liver mets and liver tumor and node, as we said, it is unlikely. So pointing towards a retroperitoneal sarcoma mostly, sir.
Okay, so the common retroperitoneal lesions are, one is the lymph node mass, still lymphoma we discussed, it is not like lymphoma. Then among the primary retroperitoneal tumors, we have retroperitoneal sarcomas. Common things are liposarcoma.
Yes.
Then we have malignant fibrous histiocytoma, neurofibrosarcomas. So all those things are possible. Okay.
Yes.
Next.
This is scroll slide of that.
Yeah, good. Yeah. So that slowly, and we can show the findings.
Yes, sir. Here it's arising from the cava-vitreal junction.
Yeah, and coming along the course of the inferior vena cava, where inferior vena cava is not seen separately, it is extending into the hepatic veins, showing the central areas of necrosis. Yes.
And the middle vein, a hepatic vein involvement here we can see.
Okay.
Then it's extending inferiorly.
See here it is involving the caudate lobe of liver.
Yes, sir. Caudate lobe.
Here adrenal we can see right adrenal separately.
Yeah, adrenal is.
Okay. Now it is displacing the portal vein anteriorly. Okay.
Yes, sir.
Yeah.
Also kidneys and pancreas are displaced, and the aorta also displaced.
Okay.
Necrotic components more here in the slides.
Yes.
There is negative embedded sign and crescentic shape of kidney.
Yes. And now posteriorly it is involving the psoas muscle.
Psoas muscle is getting compressed.
Okay. Come down. See, another thing is whenever you see a lesion along the course of the IVC, it can be some tumor even coming from the pelvis can extend into the IVC. It's very well
Yes,
known.
sir.
Some of the ovarian tumors, there are a lot of
Yeah.
case reports extending along the IVC into the heart.
Okay.
Okay,
Yes, sir.
yeah. So you have to know the full extent of the disease and okay, yeah. Next.
Yes, sir. It's extending down till the perforation.
Yes. Okay, now you sum up the findings and what is your
Yes, sir.
ladies?
So basically what we saw is a large heterogeneously enhancing mass measuring 9 into 12 into 13 centimeter in the right pararenal space, which is displacing the right kidney and pancreas anteriorly and engaging the IVC. There is central necrosis in the head lesion, and this lesion is seen superiorly extending up to the cavo-atrial junction with probable involvement of the right lobe and caudate lobe of liver. And the lesion is also seen extending into the middle hepatic vein and right hepatic vein, engaging the renal veins, but there is no thrombus. That usually when renal mass occurs, like first sign will be renal thrombus to occur. So this also rules out the possibility of a renal mass. And PET-CT was taken, which showed FDG-avid heterogeneously enhancing lesion arising from the IVC. There was no FDG-avid lymph nodal or distant metastatic lesions in this. And so the differential diagnoses were like hepatic tumor, renal or adrenal tumor, retroperitoneal tumor, like sarcoma, liposarcoma, or leiomyosarcoma. Then lymphoma or lymph nodal mass also was considered. So USG guided biopsy was done. It showed neoplastic tissue composed of spindle cells arranged haphazardly, and nuclear pleomorphism and hyperchromasia was present. Tumor cells seen around the vessels, and IHC markers showed positive SMA. So the diagnosis was high-grade sarcoma, possibly an undifferentiated pleomorphic sarcoma. And coming to discussion about this thing, inferior vena cava leiomyosarcomas are most common type of retroperitoneal leiomyosarcomas and most common primary malignancy of the IVC. 3/4 of the cases occur in women 40 to 60 years when symptomatic patients may commonly present with abdominal pain, distension, or rarely the lower extremity deep vein thrombosis. This sarcoma is like slow-growing malignancy, and the tumor may be classified based on the segment of the inferior vena cava where they involve, which may be like hepatic, renal, and suprarenal, infrarenal. And most common area to get involved is renal and suprarenal area of the IVC. The metastatic disease occurs in up to half of the cases at presentation, most commonly involving the liver, followed by lung. The tumor may be intraluminal, extraluminal, or both. The presence of tumor limited to and expanding the inferior vena cava is most likely an inferior vena cava leiomyosarcoma. And CT findings, after identifying a retroperitoneal mass that abuts the IVC, CT features which may distinguish the origin are: one, epicenter of the tumor, the size, tumor composition, extent, vascularity, and effects on the adjacent structures. In IVC leiomyosarcomas, the inferior vena cava wall is usually imperceptible at the point of maximal contact with the mass. And in other retroperitoneal tumors, the IVC usually compressed at the perimeter of the mass, and that IVC will be showing negative embedded, IVC will be the negative embedded organ. On contrast, enhanced CT, if the tumor has an intraluminal component, it appears as heterogeneously enhancing filling defect in the IVC. And for tumors with an extraluminal component, CT-guided core needle biopsy can be employed. This is the big sign and embedded kidney sign, which will roll out the which will narrow down the possibility of where the mass occurred. That is like when a mass is extensively compressing an adjacent organ, it gives the organ a crescent shape, which is called negative embedded organ sign. And the term beak sign is applied when a mass deforms the edge of an adjacent organ into a beak shape, suggesting that the mass arises from that organ. while an adjacent organ with dull edges suggests that the mass compresses the organ but not arising from it. So the point to be remembered with the about narrowing down the DDs of a retroperitoneal mass. First, we have to see the epicenter of the tumor, major bulk where it is, and the size, the tumor composition, the extent, vascularity, effects on adjacent structures, which will help in identifying the origin of tumor.
Yeah, so okay, good case. So many, some of the people has already diagnosed this correctly as IVC leiomyosarcoma. Thank you, Bribin. We'll move to the next case. Linda, you can show your case. So meanwhile, see, this is such a rare thing. In the last 20 years, I have seen only 2 cases of IVC leiomyosarcoma. So don't diagnose all retroperitoneal lesions as a leiomyosarcoma. So you would always think of a common conditions like lymphoma and other primary retroperitoneal tumors. Linda, can you start showing your presentation?
Yes, sir.
So the important features which will be helpful for the diagnosis of IVC leiomyosarcoma are the important thing is you should not able to see the IVC separately. So the lesion should involve the IVC and the extending along the course of the IVC with the areas of necrosis like this. So then only you can make a diagnosis of IVC leiomyosarcoma. Okay, yeah, last case.
Good evening, everybody. I myself, Nita Jose, junior resident of Department of Radiology from Amrita, Cochin. Today, I will be presenting the case. Is everybody able to see the slides?
Yes, go ahead.
Presenting a case of an 84-year-old lady who was comorbidity only of a cardiac issue and was evaluated sonologically in view of altered LFT. And sonologically, it was revealed that there was a mild altered ecotexture of the liver as well as IHBRD, and there was a cystic swelling posterior to the pancreas and in relation anterior to the pancreas and just posterior to the stomach. So, in view of altered LFT and USG findings suggestive of cystic swelling with a differential of cirrhosis or pancreatic neoplasm, she was later evaluated with further lab parameters, so which showed altered LFTs as well as elevation of tumor markers such as CA199 and CEA. So from the history itself, she was asymptomatic, and just on a routine evaluation, there was alteration in the lab values, and there was no history of any trauma to suggest any pancreatic other causes of cystic lesion. So coming to further evaluation with cross-sectional imaging, she underwent cross-sectional evaluation CT, which demonstrated a multi-loculated cystic swelling in relation to body as well as tail region of the pancreas with thick septa and peripheral calcification. So in this, there is no areas of peripancreatic fat stranding or any areas of parenchymal or ductal calcification. On the plain study.
Yeah, so when you see a lesion like this on a plain scan, so what are all the possibilities you'll think of?
First of all, there is a cystic swelling in the region of body as well as tail of pancreas. So, few cystic lesion differential have to come in mind, which includes pseudocyst as well as other causes such as serous, like cystic neoplasms. So, most commonly like serous cystic neoplasm, mucinous cystic neoplasm, IPMN, and most common pancreatic malignancy from our point, like adenocarcinoma, should be also a differential.
Yeah, so isolated, just a benign cyst also can occur in the pancreas. It can be a part of the other cystic diseases of the liver and the adrenal, other like a kidney, or it can be part of the very famous phacomatosis. So, do you know which phacomatosis commonly causes the pancreatic cyst? The so-called neurocutaneous syndromes. Yes, VHL, von Hippel-Lindau disease. Yeah, so that we can have a pancreatic cystic lesions. Yes, okay. Fine.
Coming to further contrast studies. So in this plain study, rest of the organs appeared unremarkable. So coming to further contrast studies, imaging studies.
This again plain scan. Go to next.
Okay. So this is that multiple images acquired. So in the whatever I have told in the prior image video slide, I just highlighted a few to show there was no ductal dilatation or standing collection or features of chronic pancreatitis.
Yes, very
So
important.
in the contrast study, in the arterial phase, in the lower chest cuts, we can see some soft tissue density lesion in the right middle as well as lower lobe segment. Coming down to the abdomen, we can see the prior plain CT detected that cystic lesion, which doesn't show any significant arterial phase enhancement.
Keep that slide, keep on previous. See, one
Yes,
other
sir.
important thing you would always rule out is whether it is arising from the stomach and bulging into the pancreas. So here it is closely related to the stomach. So things like the gastric cyst can have a bulge into the pancreas, like this. But here we are not seeing any normal pancreatic parenchyma separate from this lesion, and the stomach is mostly looks like just displaced. Okay.
Apart from that pancreatic lesion, we can see some areas of hypodensities in the liver, predominantly involving both lobes, and few peripancreatic lymph nodes as well as periportal lymph nodes are seen. There is no ascites or no other significant mesenteric or properitoneal nodes.
Okay, next.
Coming to the venous phase, apart from that soft tissue density lesions in the lung, we can see that liver lesions are showing peripheral enhancement and the loss of the convexity, normal liver convexity, the subcapsular aspect of the segment 6, and the right branch or portal vein appears to be attenuated or impinged, and IHPR dilatation of the liver. And coming to the left branch of portal vein, it appears to be normal, completely patent. However, the splenic branch, splenic vein appears to be narrowed or thrombosed, but there is no splenomegaly.
Yes, next slide. So in that static images you can show that.
So these are the areas of liver, peripherally enhancing liver lesions that I mentioned prior, which is causing obstruction to the right branch of portal vein and ISBR dilatation and splenic vein thrombosis And these are the areas of loss of normal liver convexity suggestive of capsular retraction.
So what
And
is the
apart,
importance of that capsular retraction?
there is like some fibrosis. There are many causes of capsular retraction per se.
Okay, can
But
you enumerate few?
so there is like inflammatory causes, infective causes, and more cirrhosis in cirrhosis itself, hepatocellular carcinoma, cholangiocarcinoma, and in other causes like metastasis, like from lung, from colon, from pancreas. So all these
Yeah,
causes.
so basically, it's identifying that thing, in some cases will give you a clue to the diagnosis, especially common in among the primary malignancy. Cholangiocarcinomas tend to show the capsular retraction more commonly than the CC. Then among the metastases, CA breast is the most common tumor, can show the capsular retraction, because they tend to produce the desmoplastic reaction. Okay, so that's why some of the tumors can show the capsular retraction, basically due to the fibrosis. Otherwise, in the primary cirrhosis, you can have just a cirrhotic fibrosis can have. But here, how is the background liver? Is there any features of cirrhosis?
No, sir, it just fissural widening is there.
Yeah,
Apart from
otherwise
it,
there are no
there is
nodularity, nothing to suggest a liver
cirrhosis.
fibrosis. Okay, fine. So, what are the possibilities now?
Sir, yeah, like pseudocyst comes out of like it is totally like excluded since there is no history of. She was asymptomatic for a very long period of time. There is no it should be like completely clear cyst. Then other so it the other neoplastic etiologies come like Cystic Neoplasm, Mucinous, IPMN, and most commonly is adenocarcinoma.
Yes, so you cannot neglect this as a pseudocyst, because you cannot explain the liver lesions and the lung nodules and all. Okay, even though the splenic vein thrombosis can occur in pancreatitis per se,
Pancreatitis.
but there are definitely other features which we cannot explain, and there are no features of underlying CCP, as you rightly pointed out, and there are no peripancreatic fat stranding or any other definite evidence of pancreatitis, and pancreatic duct is not dilated. Okay, fine. Next.
So, our CT finally interpreted it like multiloculated macrocystic lesion predominantly involving the body as well as tail region of pancreas with thick septa and peripheral calcification and hypodense peripherally enhancing liver lesion along with the soft tissue density lesion in the lung. So these could represent causes metastasis to distant organ, and she was later underwent biopsy from the liver. So we took biopsy from the liver. It
Can
came
please
out.
have that discussion. Yeah.
Okay.
Next.
Since it was our differential was some cystic lesions of the pancreas, so I wanted to make out as it can be pseudocyst. We can't completely exclude it. So and cystic neoplasm. So in cystic neoplasm, it's there itself like macrocyst as well as microcyst. So up by age, the most common this is an 84-year-old lady. So most common lesion is like serous cystic neoplasm, and but it will have the central calcification, that micronodular appearance also, and the other differential is mucinous cystic neoplasm. This is commonly in middle aged 40 to 60-year-old age group female or so. But this will have a peripheral calcification towards the cyst. And the other differential is IPMN, can be either from the central branch or the side branch. So I have made a flowchart on how to approach the cystic neoplasm, since our study, the case was more predominantly of cystic neoplasm. So it included how to manage a serous cystadenoma. So if the patient is symptomatic and along with it, the size of the cyst is more than 4 centimeter, it can be approached with multidisciplinary management or with serial follow-ups with CT or MRI. And if there is a doubt or in a case, they can go ahead with surgery. But in these are the case of symptomatic. Asymptomatic, they can be followed up for a period with serial imaging with CT as well as MRI. And mucinous cystic neoplasm, if it is asymptomatic, like in case of serous, it can be followed up with CT for the CT or MRI evaluation. But however, if the size of the lesion is more than 4 centimeter, it has to be undergo surgery. The other differential is solid pseudopapillary neoplasm. Like it can other neoplasm also like neuroendocrine tumor, which is further previously mentioned. It should be followed up with not only with CT or so. We should evaluate with tumor markers and endoscopic biopsies and all, and later go ahead with surgery. Then since most of the causes of pancreatic tumor are pancreatic ductal adenocarcinoma, so there are some pancreatic ductal adenocarcinoma which is having a cystic characteristic features, which is like they may having neoplastic cyst or something new neoplastic cyst. So pancreatic neoplasms with cystic change can include PDS with the large duct type of cyst and PDS with the neoplastic mucin containing cyst. So the difference between these two is just the size of the cyst. So the pancreatic ductal adenocarcinoma with neoplastic mucin containing cyst would be larger than 1 centimeter. And other causes are colloid carcinoma and pancreatic ductal adenocarcinoma with showing degenerative cystic changes. But however, this pancreatic adenocarcinoma can show cyst which is of non-neoplastic etiology, can be due to like obstruction. That is the retention cyst, like obstruction to the duct itself can cause retention cyst. And along with this adenocarcinoma, pseudocyst can also occur. That is PDS with attached pseudocyst. And these are the few causes of capsular retraction, as I explained previously. There are two causes such as intrahepatic as well as extrahepatic cause. So the intrahepatic, the cirrhosis itself can cause capsular retraction as like there's no plastic retraction. Then hepatocellular carcinoma, cholangiocarcinoma is like most commonly known cause to produce the capsular retraction. And in our case, like hepatic mets. And hello, is it audible?
Yes, yeah.
Hello.
Yeah.
Yes, yes.
Then other infective causes like hepatic inflammatory pseudotumors and causes like biliary obstruction, infection, and fulminant hepatic necrosis. Other extrahepatic causes are the diaphragm. It itself like
Yeah. Okay.
indentation
So
of the diaphragm.
yeah, we have discussed. Can you move to the next?
Yes, sir. So in our case, she was evaluated further with the USG guided biopsy, which turned out to be a moderate to poorly differentiated adenocarcinoma with tumor markers at CK17 and CK19 positivity.
Yeah, so this case is to highlight that not all cystic lesions of the pancreas will be approaching like a serous or a mucinous cystadenomas and all. In this case, the important clues where the it is not a purely a cystic lesion. Yes, there are some solid component also. Both the solid cystic and as well as there is a involvement of the splenic vein with the multiple hypovascular liver metastasis. So all those things will points toward the adenocarcinoma. And remember, even in an adenocarcinoma, you can have a lot of cystic component. Generally, adenocarcinoma will present like a hypovascular necrotic masses, infiltrating masses, but it can have cystic component due to various causes, including it can be a tumor associated cyst or a non-neoplastic cyst, or just a pseudocyst can be attached with that. So I think with that we come to the end of the session. I really thank all the three PGs, Dr. Noor, Dr. Bribin and the Dr. Linta,
Thank you,
And
sir. Thank you so much, sir.
a very nice, confident presentation. All the best
Thank you, sir.
to you. I also thank all the participants to actively involved in this, and in fact, there are few residents who could able to diagnose even the rare cases correctly. So thank you for attending this. I also thank the IRIA Kerala chapter for giving us the opportunity to present to you regarding these cases. I also thank the MedPiper team, especially Soumya, for providing the platform. Thank you again.